direction that this presentation will be is to look mostly at problems of the midfoot, and I'm going to focus on the patient without neuropathy. So, Lisa, we're about 8:30. I'm going to get started.
Okay.
Okay, so good evening, everybody. This is Mark Meyerson here, and speaking from Baltimore. So what I'd like to discuss tonight are some of the techniques that we use for midfoot arthrodesis in many different settings. So the first is, for example, in crush injuries of the foot. We will use arthrodesis quite frequently in post-traumatic arthritis. You will see an interesting example of this here, the before and after with the correction of post-traumatic arthritis. In rheumatologic deformity correction, and each of these examples that I'm presenting here now, I'm going to discuss in more depth further on in the presentation. You can see the correction we obtained there. Revision midfoot surgery. This is quite a common procedure where you have deformity, arthritis. You can see cyst formation in this individual, treated with a reconstruction. If you look at this here, this patient has a very interesting deformity with a non-union of the first ray, shortening of the first ray, tremendous cyst formation in the cuneiform, both the medial and the middle cuneiform and the lateral cuneiform. So this has to be reconstructed with lengthening of the first column. So you will see here a bone block graft. It's the only way you can restore function to this foot. If you look at the lateral view here, you will see restoration of the declination angle of the first metatarsal. And imagine trying to do this arthrodesis if you had an in situ arthrodesis where you did the arthrodesis between the first metatarsal and the medial cuneiform without lengthening. There are many complications which we will discuss later with this. You'll also notice a variety of fixation techniques in each of these examples. I use the midfoot fusion quite frequently in conjunction with correction of Hallux valgus, where there's associated arthritis. So here you can see at the base of the second Metatarsus-cuneiform joint, as well as the naviculo-cuneiform joint, some arthritis, and this is treated with a modified Lapetus procedure. But I don't think of this really as a Lapetus procedure, and I'm not really going to be discussing the Lapetus procedure at all tonight. Deformity correction, this is a very severe post-traumatic deformity where the entire midfoot has dislocated laterally. So, you know, one of the principles of correction of the midfoot is you must not only obtain an arthrodesis, but you have to get realignment. To do an in situ arthrodesis here would be technically incorrect, and you can see why. The entire midfoot is dislocated, and this is the type of correction that are obtained starting medially. So if you go back here and you look at how you're going to get your correction, with all of these deformities, the principle would be to start at the apex of the deformity. So here the apex of the deformity is medial. That's where you start. You have to loosen up every articulation. You lock in your medial column first and then work your way across laterally. You can see I've used a variety of different plates here for fixation. As I said earlier, I'm not going to discuss the Lapetus procedure in any detail, but certainly this is an important part of your midfoot fusion. This is technically a very challenging problem, is how do you correct severe adductus of the forefoot when you have deformity, arthritis of the tarsometatarsal joint? Because realistically, this patient presents with Hallux valgus. That's all the patient sees, is they have Hallux valgus and perhaps some valgus deformities of the lesser toes. And if all you do is address the hallux valgus, it's unlikely that you're going to obtain satisfactory correction of this deformity. It's a dilemma because you realize that everything, once you start correcting this, you cannot base this on the intermetatarsal angle. The entire foot has to be corrected. So you can see here I start laterally. I've removed the wedge from the lateral side of the metatarsal cuboid and metatarsal cuneiform joints, and then moved my way across medially to obtain correction. Another indication for using a midfoot fusion is following prior procedures. Here you can see an interesting example where you have severe metatarsus elevatus of the first ray with overload of the second metatarsal, perhaps even the third. Now, I really think one has to look at this and say, well, the patient presents with symptoms of the second and third metatarsal. And certainly you could approach this and say, well, I'll try some shortening osteotomies of the second and third metatarsal. But that doesn't make any sense because the root of the problem is obviously the elevated first metatarsal. So that's the way it's approached. And we'll do a bone block, lengthening. Here I'm using an allograft and a lengthening arthrodesis of the tarsometatarsal joint. So you can see that there, and this is what was obtained just by inserting a wedge. And you can see now the correction of the declination angle of the first metatarsal. Now, let's take a look at the clinical focus now. What are you going to look for when you examine these patients? Because when a patient has arthritis of the tarsometatarsal joint or the midfoot, you must think of the secondary effects that this arthritis has on the rest of the foot, so that as your foot starts to abduct, there's going to be increased pronation through the midfoot on weight bearing. You'll have hindfoot valgus, and you'll have increasing pronation of the hallux and hallux valgus. So that you cannot just focus on the arthritis of the midfoot. You need to see what the effect is of the midfoot on the rest of the forefoot and the hindfoot. So it's something you must ask, because here what happens is you'll get maybe traumatic arthritis, which is the case in this patient, but there's secondary changes to the rest of the hindfoot. Here you can see in this individual the changes, the hindfoot, the heel is in valgus. You've got, that is a secondary problem, so that if all you do is to correct the midfoot arthritis, and you leave the hindfoot in valgus, you've not corrected the problem, because that secondary process also needs to be addressed. Now, this I find a very difficult question to answer is, how do you know which joints are symptomatic, and how do you know which joints you should include in the arthrodesis? And I don't know that I can give you a fixed, absolute answer. The principle here is this. If you look at the X-ray, you can see that there's arthritis in all of these tarsometatarsal joints. You can see on the bone scan that the entire foot has uptake across the tarsometatarsal joint. But the problem is that X-rays are helpful. The scans are not helpful, and the reason is that frequently you'll have uptake in joints that are entirely asymptomatic. So I do not find that a bone scan or any other scan for that matter is really helpful in decision making. So, you know, if you look at this, I base the decision on the X-ray, but mostly I think where the pain is, where's the patient's pain, and it's not too difficult to distinguish the first tarsometatarsal joint, the naviculo-cuneiform joint, and the intercuneiform joint. And then the other principle is to avoid the lateral column in the arthrodesis. Ideally, you do not want to perform a lateral column arthrodesis. Remember, in these post-traumatic cases, these are both injuries, the Lisfranc injuries, that the arthritis is not just at the tarsal-metatarsal joint. You can see on the left here this intercuneiform and naviculo-cuneiform arthritis as well. This is a pattern which we described, gosh, in the mid-1980s. The other principle, as I said, is to maintain the lateral column motion. And I find that the X-ray here is very unreliable. Patients will often have changes on the X-ray, but no symptoms. So you cannot base your decision to do a fusion on what the X-ray alone looks like. And we've looked at this in the study that we did in the mid-1990s. When a patient had an arthrodesis of all three columns, if you included the lateral column, they were very symptomatic, and the foot was much stiffer. There was decreased satisfaction, and we had an increase in non-union, particularly laterally. And it's interesting because we switched at that time from looking at classification schemes that we had available to looking at the foot, the midfoot as columns. So you've got your medial, your middle, and your lateral column. And there's your medial column, of course, middle and lateral. And the paradox is this, that the middle column, which has the least amount of motion, is always the one that is the most symptomatic. And it would be very rare that you would do an arthrodesis for arthritis of some sort without including your middle column in the arthrodesis. Here you can see, again, another interesting example of arthritis of the entire tarsal-metatarsal joint, including the lateral column. I did not include that in the arthrodesis because the patient was not symptomatic laterally. So my preference is to leave the fourth and fifth tarsal-metatarsal joint even if there are radiographic changes present. Now the dilemma is, what do you do with these patients, though, who come in specifically with lateral column arthritis? It's a totally different problem. And these patients, I find that it's very frustrating to treat. Here you can see I've done a resection arthroplasty with interposition. I've used an anchovy of a tendon as an interposition. It wasn't terribly successful. This is what it looked like when we were done. This is not my case. It's an example of Bob Anderson's. And when Bob first described this about 10 years ago, these are small ceramic balls in the lateral side of the foot. So now everybody refers to these as Bob's balls, and that's what we call them. Now, I used to use them, and for about 5 years I did some cases, but they were never very good. The ceramic used to collapse into the metatarsal cuboid joint, and you can see, here's an example of it. You can see the ceramic spheres that have been inserted in there, and I'll show you a case here. This is a patient who presented with isolated arthritis of the fourth and fifth tarsal-metatarsal joint, nothing else. It's not that common, but when these patients present with this, you need to have some sort of a treatment plan. You can see what happened here. I used these ceramic balls with a terrible result. There was lysis around these ceramic spheres. You certainly cannot do an arthrodesis of this because you have a huge defect. So you can see what this looked like. I had to do some sort of arthroplasty, and I put a tendon anchovy in there, and then had hypermobility of the lateral column once we were finished. So that wasn't very successful. So what I've been doing for the past few years, and it's about 3 years now, all I'll do is a cheilectomy, and you'll see it here. It's not very much, but I will do a cheilectomy of that tarsal-metatarsal joint. Let me just go back there again. And you can see here, I'm just taking off that osteophyte off the base of the cuboid and the fourth metatarsal. I don't put any interposition in there. And for the majority of these patients, you're not burning any bridges. You can always go back and do another procedure. But most of them seem to be asymptomatic. And I think that that makes sense. You know, it's the same approach that we take with the hallux. A chilectomy of the hallux MP joint doesn't really make much sense because you've got a very abnormal joint, and yet these patients are frequently asymptomatic. So it's the same thing now in the lateral tarsometatarsal joint, which indeed is a mobile joint. I don't think that you can do this for the middle column, which does require a stable fusion. Now, here are some principles of arthrodesis. Firstly, bone graft is not necessary if you can get good realignment and if there are no cysts present. You must correct any deformity. You'll see here you've got abduction of the foot. You need to restore your medial column alignment, and that applies both in the horizontal and the sagittal plane. So where you've got abduction, you need to correct that abduction of the entire tarsometatarsal joint and get your declination of the first metatarsal corrected. So it's the same, really the same approach that I would use if I had an acute Lisfranc injury. I would use a bone reduction clamp, apply that between the medial cuneiform and the second metatarsal, or the medial cuneiform and the third metatarsal to help me with my correction, and then I'll follow with the fixation. Wedge resection of the tarsometatarsal joint is not a good idea because you get very severe shortening of the medial column, and that shortening is very difficult to treat. So you want to do your correction by rotation and angulation. What about the incisions? It depends on the columns. Here in this particular patient, I was doing all three columns, medial, middle, and lateral, and I use 3 incisions. Occasionally, you can, if you have the medial and the middle column involved, 1 very long incision here is enough. But if the patient has osteophytes on the plantar surface of the first tarsometatarsal joint, you need to plantarflex the first ray, and the only way you can get to the plantar surface of those osteophytes is to make an additional medial incision. So for idiopathic osteoarthritis, where these patients present with a large osteophyte or a rocker under the medial column, I'll then do an extra incision. You can see here, this is the typical approach. Let's look at this. Now, I want you to look here, look at the right foot in this patient, and note the shortening that's already present of the hallux, because this is very important when you come to correction. We start medially because it's on the plantar medial side that you have these massive osteophytes that need to be debrided. Once I'm done now and I've stabilized my medial column, look what I've done here to realign the first metatarsal is I dorsiflex the hallux. Now that is good and bad. You'll get nice realignment in doing so, and it stabilizes and compresses your tarsometatarsal joint as you're doing the arthrodesis. The problem, however, is that you get elevation of your hallux and you get a cock-up of the hallux. So if you look here, we've now done our debridement, we've got our realignment, but the hallux is short. And it gets cocked up as well. You can see very nice correction, but there's slight elevation of the hallux, and you can see that from the side. Here you can see in the pre-op x-ray why I used that medial incision in addition to the dorsal incision is because these osteophytes on the medial aspect of the foot need to be removed. But look at the secondary complication. Because of the windlass mechanism, now I've increased the declination of the first metatarsal, but I've now increased the cock-up deformity of the hallux, and that's unfortunately quite common. You'll see another example of this here. So you have to be very careful with the length of the first metatarsal. In these patients with, particularly with idiopathic osteoarthritis, you get erosive changes of the base of the metatarsal, and that will then lead to a cock-up deformity. Here's another example of that with a plantar plate applied, but again, in order to restore this, you can see the hallux is elevated. So what I will do is I will, at the time of surgery, if I see that the hallux has a tendency to elevate, I will lengthen the extensor hallucis longus at the same time as doing the arthrodesis. Here we have a very interesting problem. Let's look at the right foot. You'll see this patient who has rheumatoid arthritis has erosive arthritis of the first metatarsal cuneiform joint with shortening of the medial column, and then stress fractures, multiple stress fractures with non-unions, and actually 2 stress fractures of the fifth metatarsal. So the principle here is to start at the apex of the deformity, which is lateral. So I'm going to do a double osteotomy here. I'm going to do an osteotomy through both of these old stress fractures. You can see I've done a wedge through both of them. I'll run my pin in and then put a cannulated screw down the fifth metatarsal, because that's where I have to start. I've got to get my correction at the apex of the deformity. Once I'm done that, I'll work my way across from lateral to medial, and then eventually put in a bone block, and you can see a fairly large bone block graft is in here, lengthening the medial column to get that stable. You must ask yourself, what else needs to be done in addition to the midfoot arthritis? Do you need to do a calcaneal osteotomy? Do you need to do a lateral column lengthening, and so on? So is this part of a global flatfoot deformity? Here I've just done a medial translational osteotomy of the calcaneus in addition to that. Here we've got arthritis of the medial column. You can see here arthritis of the first and second metatarsal cuneiform joint, but very significant uncovering of the talonavicular joint. So medial translational osteotomy will not be sufficient, and a lateral column lengthening needs to be done. So I've done my arthrodesis and now a lateral column lengthening with lateral column lengthening graft. Here's a worse example of that, where you can see complete instability of the tarsometatarsal joint with arthritis, with erosive changes, and in this case these changes are actually at the calcaneocuboid joint. So I decided to lengthen it there, and you can see nice restoration of the alignment of the foot with that lateral bone block through the lateral side of the foot. When you have arthritis after crush injuries, this is, can be quite frustrating and difficult because of the skin. And it's not that easy to plan your incisions when you need to do this arthrodesis. Are you going to go dorsally, medially? How are you going to approach this? What type of fixation are you going to use? Here's a crush injury in a young woman with absolutely no cuneiform. This was entirely avascular, and you can see that here. When I opened the foot, there was no cuneiform there. It was all crumbled. So I had to work out a way to put in a very large bone block here on the medial side of the foot and lengthen the medial column. So you can see that here there's my bone graft, and I've applied a medial plate to the medial column of the foot to restore this, and you can see here what that looks like once I was done, and this is what it looked like actually after I'd taken out the hardware, which is giving her some trouble. Now I have some problems, I must say, with the naviculo-cuneiform joint, and unfortunately I have a very high non-union rate, and I'm never really quite sure what the solution is. My non-union rate's probably about, I don't know, 12, 14% at the naviculo-cuneiform joint. Here you'll see an example where I've used just multiple screws, and in some individuals this works reasonably well. I find getting these screws in is not so easy. there are plating systems which are actually a little bit easier. This is a very old DePuy plate which works on the medial column. This is a newer DePuy plate which has just been released, and it's a very interesting plate because it allows you to lock proximally on the navicular. Then you can compress on the cuneiform. Once you've compressed it on the cuneiform, you lock on the cuneiform, then you compress on your metatarsal, and then you can lock it on the metatarsal. So here you can see an example of this. This is a locking compression plate, and here you can see what's being done. I prepare the joint. I don't know how all of you prepare your joint, but I find that very aggressive perforation of the joint, and both with a 2mm drill and a small chisel seems to be the best way to prepare the naviculo-cuneiform joint. Here you can see the plate being applied. There's a nice part of this plate is that with this plate bender you can do in situ bending of the plate once it's been applied proximally. Here you can see an example of this where we've got a naviculo-cuneiform metatarsal arthrodesis, and I've used a combination of plates because the plate over the middle column is an orthohelix peanut plate, which works very nicely in isolation there. So the way this particular plate works is you lock the screws in the navicular, you compress it in the cuneiform, you then lock it in the cuneiform and the navicular. You can then compress it on the first metatarsal, and then you lock it. Now, bone loss, I've shown you a couple of cases with bone loss, and this gets to be quite important when you have erosive changes at the metatarsal, because you can see here, if you did an in situ arthrodesis, you have a very short first ray. If you then have to plantarflex the first ray to reestablish your declination angle, your hallux is going to cock up very severely. So the lengthening graft here becomes important. And of course, as you put the graft in and distract your medial column, be careful as to what happens on your middle column, because you may distract the second metatarsal as well. I'm not going to talk too much about the Charcot midfoot, but let's look at a couple of clinical examples. Here's a difficult problem. This patient who has diabetes and some sensation presented after multiple surgeries. This was some trauma, had many attempts at arthrodesis. And if you look here, this is what I had when I opened the foot, got the bone debrided, and I had to now try and work out a way for fixation. And this is not an easy way to fix this, because I guess you could use a plate, but this is a very good time to consider intramedullary fixation. Here you can see how this is done. I'll run a pin from the head of the talus out the back, and the pin exits just behind the fibula. So there's the pin coming out behind the fibula along the course of the talus. I then reduce the foot over the talus and then run a fully threaded screw, and I find that fully threaded screws work better than partially threaded screws in these patients. I'm not too concerned about compression here. There you can see the pin going out the back, and this is what it looks like once I'm done. And you can see here the realignment that are obtained in this patient with intramedullary fixation. Intramedullary fixation can be used in other settings and with different types of fixation systems. This is another patient with Charcot midfoot arthropathy. She had a number of procedures done already, and a few of them had been done with an external fixator and a small wire fixator. So how do you approach this with it's a totally unstable midfoot? So you can see here how unstable it is, both in the sagittal and horizontal plane. So you've got to work out some sort of system, and I chose to use intramedullary fixation here as well, and this is what I use. This is another intramedullary system. It's called the Tarsal system by Extremity Medical, and if you look on the left, you'll see that the screws are broken. I kept her non-weight bearing for about 3 months. I did the surgery a year ago, and even though the screws are broken, her foot is still quite stable, and I suspect that the screws were holding this for just long enough that the foot was stable. And this is an intramedullary system which locks from the metatarsals further posteriorly. Here's another example of the same system with a Charcot foot which is unstable with quite nice realignment. In this patient, you can't see it here, but a few of the lateral screws broke as well. You can also see here I was trying to get a screw in the third metatarsal, but I couldn't engage it, so I just left this screw sitting in the metatarsal and didn't put a locking screw in proximally. There are other systems that are available for treating the midfoot. Here, these are custom plates that are made by Helix, which are very nice. They sit and contour perfectly over the tarsometatarsal joints. Here's another example of a midfoot arthropathy. I don't remember, I think this was a post-traumatic arthritis, where you can see I've used this tarsometatarsal plate here and a medial peanut plate. One of our fellows presented this in a series of about 70 patients at the summer meeting with a very good rate of arthrodesis. Here's another example here. This is idiopathic arthritis of the midfoot and tarsometatarsal joint. So I included the Hallux metatarsophalangeal joint. I've not seen any problems when you fuse the Hallux metatarsophalangeal joint as well as the tarsometatarsal joint. So I don't have a problem doing a combined arthrodesis, and this is what the plate system looks like, and it contours right over the tarsometatarsal joint. I used the same system of plates in this patient with a neuropathic deformity with abduction. There wasn't terribly much of a rocker bottom deformity, and you can see here, it's not too bad, it's not perfectly corrected, but certainly from there to here, we've got reasonable correction of the alignment of the foot. Another example here, again, I obtained an arthrodesis. What I think is very important here when you're doing this, remember what I said earlier about what is the effect of the midfoot on the hindfoot. And look how flat this calcaneus is. It's lost its pitch angle completely. In these patients with a rocker bottom deformity, you always will have hindfoot equinus and a contracture of your gastroc or Achilles, so that must be included. So the first thing I do with this foot is actually do an open lengthening. I don't do it percutaneously. I'll do an open lengthening of the Achilles, and you can see here I've done a calcaneal osteotomy here and pulled the calcaneus inferiorly so that I can restore the talar declination angle and the calcaneal pitch angle, which was done there. Non-union can be very frustrating. Here's a patient of mine, and I think I operated on this patient 4 times. There's the first surgery. She had a non-union. Here was my second surgery, and I used bone graft and demineralized bone matrix. I got another non-union. There's the third surgery. Now I've used an implantable bone stimulator. I've got another complication here with elevation of the first metatarsal, and I had to operate on her again, ultimately putting in a bone graft here to increase the declination of the first metatarsal. So I think, it's interesting as this has all evolved. We now have different plating systems to use for the midfoot, for the tarsometatarsal joint that are unique. They afford us much better fixation and certainly can be used in conjunction with screws very nicely. So that's it. I thank you for your participation. If there are any questions, you can either ask them now or you can type in your questions into the question and answer box. So I'm happy just to stay on the call for as long as you like. So any questions from the participants?
Really happy and appreciate the presentation.
I could not hear anything there. Unfortunately, I did not hear that question. If that was a question for me.
Mark, can you hear me now?
Yes, I can hear you. That's perfect. Felipe, yes.
Well, it was nice. I appreciate it, and I saw that it was possible to see different problems in the Liszt Frank and different ways to think about this, no? And I have a simple question to you, Mark. You prefer to use not cannulated screws when this is a simple arthrodesis like an in situ arthrodesis, or no?
Yeah, you know, that is interesting. Many years ago, and Felipe, when you were working with me, and it's many years ago, there was a time I was not using partially threaded screws because at the time I thought that perhaps it was more important to get alignment and rigidity. And I think that compression actually is important. It is important at the tarsometatarsal joint. When you're dealing, however, with a neuropathic deformity, then compression is not important and stability is much more important, and then I'll use a fully threaded screw. So when I've got major instability, all I want to do is get that foot stable, even if it means that I don't have an arthrodesis, as you saw in a few of the cases, but the alignment was restored.
Nice. And do you prefer nowadays to use the plate and instead you put just the screws, Mark? Do you think that is better for the stabilization and for the compression?
So I think if I'm doing an isolated, let's say a first tarsometatarsal arthrodesis, where a Lapetus procedure, for example, I would say that 90% of the time, maybe more, I just use 2 screws. I do not use a plate. If I am including the second and third tarsometatarsal joint, I find it quite hard to do the entire correction with screws. It's not so easy. You know, you put your screws in, you split the metatarsal. You don't always get good compression and fixation. So if I'm doing the second and third, I will now use a custom plate, and you saw an example of that. If I have very severe deformity and it involves the entire medial column with abduction and arthritis of the naviculo-cuneiform joint, then I use plate as well, and I put the plate on medially, and I prefer a stabilizing medial column plate to screws. But of course, screws are still, I think, for the majority of individuals, acceptable. We have access here to the use of these custom orthohelix plates, and I think that if you have access to a custom designed plate specifically for this, you can use it.
Okay, nice, Mark.
Okay.
Hey, Mark.
Yeah.
Hey, Wes Palumbo, how you doing?
Hi, Wes. How are you?
I'm doing good. Hey, listen, I just had a question for you. I find it on some of the Lapetuses I do and some of the midfoot fusions that oftentimes the midfoot, even the first EMT joint doesn't fuse. And many of the times they're very asymptomatic.
Yeah.
Do you find a lot of that?
Yeah. Now, I won't say a lot. It's interesting that I saw a patient in my clinic today that I did an arthrodesis on about a year ago, and he has a non-union, but was entirely asymptomatic. So if I'm doing a Lapetus, I will honestly say, and this is the bottom line, is I have not seen a non-union from a Lapetus procedure now in about 5 years. And I changed my technique. Up until then, I had the same non-union rate that everybody has, 10% or so. And I remember a friend, I think it was from Switzerland, Pascal Ripstein, said to me that what he does was very, very aggressively prepares the joint, very aggressively perforates it, chisels the joint, and then uses 2 cross screws. And since I started doing that, I cannot remember a non-union for an isolated Lapetus procedure. I just cannot remember it. It does occur, however, when you have other risk factors, where you have problems with neuropathy, other deformity. In general, your question is correct in that these patients can be asymptomatic, so that if you have a non-union, I would wait about a year and see what happens, because oftentimes the patient is not symptomatic. I wouldn't rush in to redo it.
All right, thanks.
Anything else? Well, if there are no more questions, I'll close the